So we are streaming on YouTube. We will be live exactly by. So we are live streaming it.
Yes, yes, yes. Doctor will join soon.
Okay. Hello, sir. When can we expect the doctor to join, sir? Hello, sir. Hello. I'm audible?
Hello.
Hello. Hi, doctor. This is Dhruv here from the technical team. I'm audible to you, sir.
Hello.
हेलो
Sir, we can start the session.
सर आवाज आ रही है हेलो हेलो सर आवाज आ रही है हेलो 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 सर आप अनम्यूट करिए सर हेलो सर प्लीज अनम्यूट योर सेल्फ
हेलो.
हाँ सर आवाज आ रही है
हेलो.
हाँ सर आवाज आ रही है मेरी
हाँ, आवाज नहीं आ रही है आपकी.
आवाज नहीं आ रही हेलो हेलो हेलो
हेलो.
आवाज आ रही है सर मेरी
हेलो. हाँ, आ रही है आपकी आवाज नहीं.
ठीक है सर मैं स्क्रीन शेयर कर रहा हूँ
हाँ, स्टार्ट कर दो ना इसको.
हाँ मैं कर रहा हूँ स्क्रीन शेयर कर रहा हूँ
Doctor, we can start, sir. Doctor, we can
स्टार्ट करें.
यस सर यस सर यस सर
हेलो एवरीवन. I am Dr. Rahul
start,
Seth
sir.
here, MD Pediatrics. Today we are discussing about cough. There is a cough is a force expulsive maneuver usually against the closed glottis and which is associated with the characteristic sounds. There is three phases of cough. First phase is brief inspiratory phase to prime the lungs with a volume of air. And second phase is a comprehensive phase characterized by expiratory muscle contraction against a closed glottis, needed to ramp up intrapulmonary pressure. And third and last phase is the expiratory phase, during which the glottis open and high velocity expiratory airflow occurs. And on the basis of duration, the cough is divided into two types: acute cough and subacute cough. Acute cough is defined as cough lasting for 3 weeks or less in duration, and subacute cough is defined as cough lasting to 3 to 8 weeks in duration. On the basis of nature, cough is divided in two types: dry or non-productive cough, and second is the productive cough. Dry and non-productive cough which does not expel mucus or phlegm from the respiratory tract, and productive cough is cough which expel mucus or phlegm from the respiratory tract, sputum volume more than 10 ml per day. Cough and its prevalence, acute cough prevalence is 9 to 64%, and chronic cough is more than 10%. And prevalence in India ranges from 5 to 10%. The spectrum of potential causes of cough is wide, with diversity in the symptomatic management at primary care. Undiagnosed, unresponsive patients require a multidisciplinary team approach. International guidelines may not address the region-specific needs, especially in tropical countries which have different etiologies and risk factors. What is productive cough and what is dry cough? There is a difference in nature, secretion, site, significance, and duration. In nature, wet cough, there is moist and rattling sound, and in dry cough, harsh and non-productive. In wet cough, secretion present; in dry cough, secretions are absent. Dry cough originates from upper airway, and wet cough originates from lower airway. Dry cough mostly benign in nature, and wet cough is often pathological. On the basis of duration, mostly wet cough persists for more than 4 weeks, which is red flag, and dry cough is generally often transient. Common cause of wet cough is infection or bronchiectasis, and dry cough is mostly due to viral infection, asthma, or allergies. Productive cough. Why pediatric productive cough matters? It may mostly cause discomfort in child, as in chest pain, throat irritation, and fatigue. Due to wet cough, dry cough, there is poor sleep in child, reduced activity, and progression risk may lead to chronic supportive lung disease and bronchiectasis. Wet cough leads to anxiety and stress, sleep loss, frequent visit to doctors, and financial burden. High consultation, medication overuse, diagnostic burden, and chronic disease load are main in productive cough. Next, cough most common reason for medical consultation in worldwide. Prevalence of acute cough 9 to 64% and chronic cough 7 to 33%. India mostly have 57% dry cough, 40% productive cough. Treatment effective, decrease duration and severity. If inadequate treatment, increase risk of chronic cough. Acute cough among children. Most common cause is the common cold, and second one is bronchiectasis, bronchiolitis or bronchitis. Third most common cause of acute cough in children is asthma. Fourth is whooping cough. Common causes of chronic cough in children are post-infectious, that is typically show spontaneous resolution over time, and second one is airway infection, that is protected bacterial bronchitis, chronic suppurative lung disease, bronchiectasis, cystic fibrosis, immune deficiency, ciliary dyskinesia, alpha-1 antitrypsin deficiency, tuberculosis, and atypical mycobacteria. Third category is airway anomaly. Airway anomaly which produce the chronic cough is the primary or secondary tracheobronchomalacia. Second is congenital airway and pulmonary malformation. Third cause of chronic cough is airway inflammation, like asthma, eosinophilic bronchitis, environmental pollutants. Fourth cause is airway aspiration. Next slide. Cough for diagnosis of cough. Mostly patient with acute cough have history in physical examination. We see red flag signs and initiate further assessment and indicate hospital referral therapy. Differential diagnosis of productive cough is acute, which is persists for less than 3 weeks, in which mainly causes of acute bronchitis, viral or lower respiratory infection. Mostly wet cough are self-limiting. Pneumonia associated with fever, tachypnea, focal crepitations. Second one is the subacute cough. Most common cause is post-infectious cough gradually resolution. For cough management, algorithm of management is first a patient present with cough, complaint of cough. We see the which type of cough, sound, intensity, and frequency. Then we take medical and drug history, risk factor associated with symptom. Then we do physical examination and plan for treatment. Management of cough, that is the two types. First is non-pharmacological and pharmacological. Non-pharmacological treatment consists lifestyle modification, and in pharmacological treatment we give cough expectorant like mucolytics, bronchodilators, mucokinetics, and secretion enhancer. And in antitussive, which is mostly centrally acting non-narcotic like dextromethorphan, and narcotics like codeine, phalcodeine, ethylmercaptan. Management of cough, IM algorithm for pediatric cough. If a patient cough is wet cough, we give expectorant and mucolytics. And if resolved, then we stop treatment. If unresolved, then attempt sputum culture, treat with antibiotic for protected bacterial bronchitis. If persistently unresolved after prolonged course, investigate for underlying disease. In case of dry cough, we start with demulcent and antitussive. If unresolved, check for the irritants and allergens. We give 4 to 8 week trial with inhaled corticosteroid cough syrup or supportive therapy. Follow for 4 weeks. If unresolved, investigate for underlying disease. Role of individual molecular productive cough. Guanfacine in management of productive cough. Guanfacine is demonstrated a well-established safety and tolerability profile in adult and pediatric population. Dosing range is 200 to 400 milligram orally up to 6 times daily. Allow flexible dose titration to allow an increase of plasma concentration. Role of levosalbutamol, ambroxol, and guanfacine on productive cough phase 4 clinical trial conducted with 23 pediatric specially investigators. Reduction in the severity of cough. The triple combination levosalbutamol, ambroxol, and guanfacine was found to be safe and efficacious in pediatric cough. Role of bronchodilator in productive cough, relieve bronchospasm, especially used in wet cough and cough with wheeze like asthma. Second, improve airway caliber. Add mucus clearance and better airflow, help secretion clearance. Levosalbutamol in productive cough is adverse events were noted in 46 cases. The adverse effect caused by levosalbutamol is tremors, palpitation, and vomiting. Most of these adverse events were mild and transient with nothing requirement treatment withdrawal or discontinuation of therapy. Terbutaline is also used for productive cough. Efficacy and safety for the combination of levosalbutamol and ambroxol and guanfacine for the symptomatic treatment of productive cough phase 4 clinical trial. As compared to baseline at visit 2 or visit 3, there was reduction in 43% and 84% at visit 2 and visit 3 respectively. So levosalbutamol, ambroxol, guanfacine combination is very safe in productive cough and cause significant improvement on second and third visit. Use of antibiotics in cough. Patient present with cough, acute cough and upper respiratory infection or and not systematically very unwell or at high risk of complication, we generally not start antibiotics. High risk of complication, we start antibiotics, and systematically very unwell patient offer immediate antibiotics. The usual course of acute cough up to 3 to 4 weeks, and managing symptom and self care. If antibiotics are not prescribed, advised by note with an antibiotic, advice on possible adverse effects including diarrhea. Antibiotics in acute cough, when and why? Cough. Caution should be exercised while prescribing antibiotics with high risk of complications. People with pre-existing comorbidities, yeah, like HIV or tuberculosis, and children born prematurely. We generally use antibiotic very precautiously. Or people more than 65-year-old with two or more of the following, or more than 80 years with one or more of the following. First is hospitalization in previous year. Patient with the type 1 or type 2 diabetes, or history of congestive heart failure, or current use of oral corticosteroids. Patient to be asked for clinical approach. Is cough a predominant symptom? If yes, it suggests an airway disease. If yes, then is it dry or wet? Is dry, then it is upper airway disease, or wet, then it is lower airway disease. If there is a past history of recurrent cough, it suggests reactive airway disease. If there is a personal or family history of atopy, then we ask for, is the cough worst at night, soon after lying down? This is postnatal drift, or later in night or early morning, then it support reactive airway disease. Third is the onset of cough is sudden, then inhale foreign body may be a cause, or over a few hours, reactive airway disease may be a cause of this cough. Progress. If cough is recurrent and episodic, then asthma is our diagnosis. If progressive and progressively worsening, then it may be pertussis or mediastinal mass compressing airway. Conclusion. Cough is one of the most common medical complaint, accounting for as many as 30 million clinical visits annually. 30 million. The mainstay of cough management should be symptomatic treatment. The short-term use of ambroxol or bromhexin is recommended to manage productive cough, and use either an acetylcysteine or guanfacine. Short-acting beta-2 agonist bronchodilator with or without short-acting muscarinic antagonists are recommended as initial treatment for an acute exacerbation. Levosalbutamol should be considered as the first line for the treatment of cough in children below 3 years of age. Combination of levosalbutamol, ambroxol, and guanfacine is safe and as well as efficacious for the treatment of productive cough. Thank you.
Thank you, sir. Thank you very much for your valuable time.
Okay, welcome.
Thanks from Grandmark, and thanks all attendees also. Thank you very much, sir. Hello, technical team. Hello, technical team. gift दे दे.
Hello, sir. Hello. Hello, sir.
Hello.
Yeah, can I conclude, sir? Sir, can I conclude?
We continue on next 5 to 10 minutes.
I'll make you the host, sir. Can you end it from your side?
Hello.
Yeah, sir. Hello.
Session has been done. We can end after 5 to 10 minutes.
Is it okay if I make you the host of the session and you
Hello.
can end it from your side? Is it fine, sir? Sir.
Okay. Okay. After
Yeah.
5 minutes, you can end this session.
Sorry?
After
Sir, your
5 minutes,
voice.
you can end this session.
Yeah, that's what I'm trying to tell you, sir. Can I make you the host of the session and you can end it from your side?
Okay. Make me the host. पैसा देना है डॉक्टरों तो वो करना पड़े